Good evening. My name is Alan Katz, and I am the chairman of American Public Square at Jewell. I want to thank you for joining us at tonight's program, which is entitled From Resistance to Resilience. This is the second part in the three-part series on mental health in our community, where we will be addressing the issues surrounding mental health and mental illness through three distinct lenses. Tonight, we will address how politics and policy play a role in mental health, examining how politics and policy factor into the mental health of our nation. I want to thank each of you for being here for this important conversation. American Public Square is committed to our mission of improving the tone and quality of public discourse and to help our community meaningfully address society's most perplexing issues. We rely on the support of members to do this. To those of you who are already APS members, we want to thank you. And to those of you who are not members, I hope you're going to consider joining today. You can learn more about membership at our website at americanpublicsquare.org. We have partnered with the Kansas City Public Library on fact-checking for our program tonight. Jenny Starr is a health and wellness specialist on the community reference team at the KC Public Library. She is the author of the fact sheet for tonight's program, which is available on our website. And additionally, she will serve as the fact checker for this evening's program. Special appreciation goes to our presenting sponsors, the City of Kansas City, Missouri, the Hall Family Foundation, H&R Block Foundation, Sue Seidler and Louis Nerman, PlexPod, William Jewell College. And the program is generously supported by the Health Forward Foundation and KC Common Good. Nisha Snell, the APS program manager, will serve as your roving reporter for tonight's program. As always during American Public Square programming, we welcome questions from the audience. Our roving reporter will be watching for any question you may have for our panel. Please feel free to type these into the Q&A section of Zoom. To request a fact check, please utilize the same process for asking questions. Just be sure to signify that you're requesting a fact check instead of a question. If you're watching on Facebook, you may ask your question by posting in the comment section. It is now my privilege to introduce tonight's panel moderator, Janet Calkins, who is the Assistant News Director at Fox 4 News in Kansas City.
Thank you, Alan, and good evening. We certainly appreciate you joining us tonight. As your moderator, my intent is to engage in a balanced dialogue with our panelists. In the first event of our series, we delved into the socioeconomics of trauma. Tonight, we will explore the politics and policy of mental health in our community. With that, let me welcome tonight's panel. Dr. Bandy Lee, a forensic psychiatrist and violence expert on the faculty of the Yale School of Medicine. Dr. Lee is also the president of the World Mental Health Coalition. Also joining us this evening is Dr. Brandon Davis, the assistant professor of law and society at the School of Public Administration at the University of Kansas. And our third panelist this evening is Dr. Benjamin Miller. He's the Chief Strategy Officer at the Wellbeing Trust. You can find each of our panelists' biographies on the American Public Square website, along with tonight's fact sheet and mental health resource information. Obviously, the causes of mental health are important to each one of us for a variety of ways, and we do want to remind you that if you or someone you know is suicidal or experiencing emotional distress, you can contact the National Suicide Prevention Lifeline. That number is 1-800-273-8255. They have trained crisis workers available to talk and offer hope and help 24 hours a day, 7 days a week. With that, let's jump into tonight's topic on politics and mental health. And to do that, we'd like to begin with a bit of a historical look back, taking a look at high-level history of mental health and policy in the United States. What has it looked like since the last pandemic in 1918? Where are we today with mental health policy in the context of where we have been? And Dr. Davis, I'd like to begin with you for those questions.
Okay, thank you. I appreciate you having me. It's a pleasure to be with you all. So I guess I can try to elaborate on where we are now by just giving some understanding about one area of society where was getting a lot of attention as far as like lack of mental health services, and that's in our schools. And so we know now that there are probably 14 million students nationwide who do not attend schools with social workers, counselors, psychologists, or any social service provisions whatsoever. Even in the states of Kansas and Missouri, none of the schools meet the recommended ratio for student to counselors in the school systems. But we do know that all these students go to schools with police officers. And this is important because even in Kansas and Missouri, not to even talk about Black boys and Indigenous boys, but Black girls are 4 to 5 times more likely to be arrested in schools as opposed to their white counterparts. And we know that this type of criminal justice contact has really negative effects on well-being, psychological well-being. It changes the environment of the school. You can have 2 different types of people in the same school climate, and both of those individuals are experiencing schools differently and separately from one another, which has large effects or great effects on that child's well-being. We also know that you cannot separate these stressors from their environments. And so these policies of putting more money into the carceral state and expanding the carceral state into our schools is a new policy formation that is causing more harm to the children in those communities, because they often also live in communities that are also simultaneously over-policed and under-policed. And we know that family member incarceration during childhood and also adverse childhood experiences are effects of having someone in your family incarcerated or having contact with the criminal justice system.
Thank you, Dr. Davis. Dr. Lee, I know a great deal of your research has been focused on those who are in incarcerated situations and violence in particular. Would you care to speak about how our mental health policy looks now compared to what it might have nearly 100 years ago in the pandemic of 1918?
Well, in many ways, we have returned to the situation we had been in 1918. Around 1918, there were many individuals who were institutionalized, and that included mentally ill individuals who were imprisoned. And over time, we have had a greater proportion hospitalized as opposed to incarcerated. But around mid-century, I would say the ratio had been the most humane, if you will, in terms of having more mentally ill individuals in hospital settings where they would get treatment instead of being penalized for their illness. Now the ratio has reversed again to the way it was earlier in the century, where most mentally ill institutionalized individuals would be found in prisons and jails and not in mental hospitals. The ratio is about 9-to-1, and therefore we're back to the situation where we were earlier in the century. Now, that poses many problems because mental health treatment cannot be properly offered in a carceral setting where other priorities may interfere, usually said to be security priorities, but often institutional priorities such as overcrowding and having certain inmates be separated or finding room for them takes greater precedence over caring for them or making treatment accessible. And so it's a dire situation. I would say one of the emergencies that mental health as a field is facing.
Thank you, Dr. Lee. And Dr. Miller, I see that you're nodding in agreement there. It seems you might have something to add to that.
Oh, absolutely.
Those thoughts.
Absolutely. And thanks for the question, and thanks for having me on here. You know, I think as was just mentioned, we've traded one set of bricks and mortar for another in how to take care of individuals that have mental illness. And just to go back and look at the history here, if you want to look at this through a policy lens, 1963 under President John F. Kennedy was the first time we saw a major piece of federal legislation that tried to get away from housing people solely in mental institutions or hospitals or psychiatric settings. And unfortunately, the repercussions that I think you heard from Dr. Lee and Dr. Davis here are really, especially in the criminal justice system, is because we never truly adequately invested in a system of care that can take care of people in communities. And that is something that I hope we talk a great deal about tonight, because at the crux of this, to address mental health and addiction in a most appropriate and comprehensive way, it's going to have to rely on us to re-examine structures that are somewhat artificial in nature, somewhat continue to fragment us in ways that do not work in the work best towards our patients and our families. So for us, I mean, from my perspective, is that if you look at the history, starting in '63, moving on up to the Affordable Care Act, we've been trying to address mental health, but what we've been doing is tinkering. We've been tinkering at the edges of trying to build something that just structurally has never had the right resources invested in it to truly make it an integrated, comprehensive system of care.
All right, well, I think we've established some of what the problems are. We're going to try to dig through and look at some potential solutions tonight as well. And that leads us right into the conversation of policy. We know that the landscape is vast and complex, daunting certainly for people, to say the least. So given your role, where do you see mental health fitting into the current political and policy landscape? Dr. Miller, I'm going to kick it back to you for starters.
Well, where it should be fitting and where it is fitting are two different things. It should be at the center of all our discourse nationally around our COVID response and recovery. It's not. And unfortunately, if you look at what Congress has done right now, they've continued to marginalize mental health by only putting around $425 million into SAMHSA to address issues of mental health and addiction. If you just want to put that into comparison to the $2 trillion that went into the rest of our communities, it's about 0.02%. So it's what I would describe budget dust. It's not meaningful enough to provide adequate solutions to what many of us are going to be facing. Now, I have to say, policy is one of these areas that gets a little muddy for folks, and I want to simplify it just for our conversations tonight. Most of us, when we talk about policy, especially the big P policy for healthcare, we talk about health insurance, and that's appropriate. If you look at any of the debates that have happened, we talk about coverage, and that's going to be essential. But the other parts of policy that are essential for us to really embrace, especially now, are around delivery and how we finance care and where we finance care in our schools and our criminal justice system. If we're not ready as a nation to have a conversation on how to almost restructure and radicalize the way that we pay for and deliver mental health care, I just don't know a better or more propitious moment than the now.
Thank you, Dr. Miller. Dr. Davis, would you care to remark on those thoughts?
Yeah, I would say that one of the primary things I think are areas of concern is anxiety in politics. Anxiety is important because it produces engagement, but that engagement is not necessarily always good engagement. And so when political elites are saying things that cause people to be anxious, or things that are happening that are causing people to be anxious, it makes people seek out information about that thing or that topic that's making them anxious. The problem with that is that a lot of people seek information to confirm their beliefs that they already hold. So if someone says that there's a caravan coming, they're going to invade the country, people that makes them anxious seek out information to confirm that these individuals are coming to invade. And so it also triggers the anxious individuals to become more trusting of the political elites that are producing the anxiety through the rhetoric. And that produces a more of a likelihood that they can be manipulated by those individuals. So anxiety is an important thing in politics, and it should be taken, we should take a good look at it, because anxiety has been up since 2015, 2016, concerning the political arena in and of itself.
Dr. Lee, where do you see mental health fitting into the current political and policy landscape?
I think we greatly underestimate the degree to which politics and policy can influence mental health. We make a distinction in psychiatry, for example, between clinical psychiatry and public health, or preventive psychiatry. And we heavily invest, if we ever do, in tertiary clinical care, that is after people have become sick and actually are unmanageable in society, as opposed to preventing many of the conditions from growing worse or preventing them from happening in the first place. And that is where policy and politics play a role. And we can go back to the 19th century German physician's word, Virchow's words, that said, medicine is but a social science and politics is medicine writ large. And I believe that that is an awareness that policymakers should have, because every bit of policy shift, in fact, has a cascading effect in terms of the mental health of society. And so there's a great deal we can do with very little investment if we were aware of the consequences of our actions. Now, the flip side of it is that we could also do a great deal of harm. And there needs to be more education around those issues as well. And simply to bring more awareness into policymakers and politicians that mental health is important, that it's not a given, and it's not any different than physical health. Just as we invest in public health and hygiene and care of our bodies, we also need to educate and promote a culture of caring for the mind.
Excellent, thank you. We know that we're living in incredibly uncertain and unusual times. I think the last 6 months or so have shown us all of that. So it seems we've established that we're probably not doing enough as a country to address issues on the front end before they become real crises sort of scenarios. And certainly the existence of COVID-19 has shined an even stronger light on some of the failings of the American healthcare system and public health. What lessons do you think we can learn from COVID that are specific to mental health, and how might we be able to advance these lessons through policy? Dr. Davis, I'll kick it to you for now.
I think one thing that COVID is made readily apparent is that mental health is it's hard to say it over and over, it's just as important as physical health. And in times like these with uncertainty, and you're putting more responsibility, especially on parents, to be not only parents, but also breadwinners and teachers and gym teachers and entertainment centers and stuff like that. And it just puts so much more stress on an individual, which could cause them to have adverse psychological effects or something like that. And so I think it's put readily apparent that, a lot of these things that we think are things that people do to themselves or must be because of they're a bad person or something like that is not true at all. It's the fact that there's a level of stress that people are used to maintaining. And if you change that level, and like we did with COVID-19, you can cause people to have certain reactions to that. It could be psychological and it could be physical. A lot of times the stress can come through as a physical ailment. And so I think COVID-19 was really put on the table that our mental health is just as important as our physical health. And certain things happen that are out of our control that can cause our mental health to degrade.
Do you think it's possible that there's been some positive effect in terms of people perhaps destigmatizing mental health concerns because more Americans maybe are experiencing them for the first time, that perhaps people feel more comfortable talking about it? Or do you still think the stigma is a big hurdle that we're working to overcome?
I would say that maybe for individuals in certain situations, they're seeing that it's not, it's stigmatized or whatever. I think one positive thing is the telehealth. I think access to mental health has increased some because we can't get out and about like we used to. And so I think that is a positive thing. I think maybe people having that telekinetic, not telekinetic, but that telehealth portal are maybe more likely to access mental health services, that they wouldn't have been as willing to walk into the door. And so that may be a possibility, but I do think that the telehealth opening it up is a positive thing.
That's a great point. And I do think the flip side of that coin certainly is that people may be feeling more isolated and more, just locked to themselves because of some of the different, regulations across the country and the stay-at-home orders and those things. Dr. Miller, what lessons do you think we can take from this COVID-19 situation that are specific to our mental health?
Well, I do want to pick up on the one thing that Dr. Davis mentioned, because I think that if you look at pre-COVID, getting access to mental health was challenging at best. And some of the survey data that was available looked at how, most folks in this country, 96 million in one survey, had to wait over a week to get access to mental health services. And that's actually pretty decent. For some, if you're looking for a specialist like a child and adolescent psychiatrist, you could be waiting months, and depending on your state and location. So I think that what COVID has done is it's allowed folks to get access in a lot easier ways, whether that be through your telephone, your computer, whatever. Those rules are temporary, and a lot of folks right now are out there fighting for them to be continued and ultimately made permanent. So I think that's one thing that is definitely a major takeaway, positive takeaway from this. The second thing is, and I think you were alluding to this with your stigma comment, is that it's allowed us to all have a different sense of empathy on how millions of Americans probably felt before COVID. There's a lot of folks that have been socially isolated and disconnected for a long time, whether that be due to mental illness or some other issue. And so what this has done is it's somewhat leveled the playing field on how we all experience something as dramatic as loneliness and isolation, which we know have been at historic rates. They've been increasing ever so slightly over the last several years, and their negative impact on our health and well-being is profound. Previous Surgeon General had written an entire report on how this could literally be as deadly as smoking and obesity to us. And yet here we are in a shelter-in-place pandemic. And the irony of that is that we need each other now more than ever before. And that's where I go back to the empathy. I think that this is a moment for us to really reflect on how we take care of each other in our communities. A moment for us to reflect on how much we are there when our fellow brother or sister is going through a struggle. And instead of turning a blind eye and ignoring it or pretending like it's not a real thing, we embrace it. And we look at it square in the eye and we say, you know what, it's okay to not be okay. I'm here for you no matter what. This is not a moral failing. This is something that we can help and we can address and we can treat together. If we come out of this pandemic and we're able to talk about mental health much more openly, then I have to say, I think that's a pretty good thing. Now, I don't want to lose any more lives, and I don't want people to, die prematurely from any kind of preventable cause. But I do think we as a nation have got to re-examine our social contracts. And a major part of that is how we talk to each other, how we embrace each other for mental health.
That leads right into the next piece of the conversation that we were going to tackle, which is, let's talk about what could our future look like if we begin to restructure our communities, just take a different vision for health and well-being and what that looks like for Americans. Dr. Dr. Lee, would you please lead us into the next part of that discussion?
Yes, I think I would agree with Dr. Miller as well in terms of empathy and connecting. COVID-19 could be a common shared experience that could bind us together and unite us in our struggle against this common threat. And to be able to talk about this, to make this the center of discussion and not just in the periphery. A study from over a month ago showed that up to 75,000 deaths could result from suicide and depression, and suicide. And so we ought to take mental health as seriously as the infectious disease itself.
Dr. Davis, one of the key areas that we could look to restructure is what the future of policing looks like. We've obviously had a heightened awareness and a lot more discussion the last few months about policing and what that looks like. But you've actually done a tremendous amount of research. You mentioned some of it a little bit earlier in terms of young Black women and how those systems in place are impacting them. Certainly you're free to speak on that, but also to the larger focus of what the future of policing might look like with a different lens on mental health.
Well, I would say this. I know that we all rightly so are attracted to the major events like the murder of Breonna Taylor, things like that, where the police are killing people. But I think to talk about the future of policing, like we have to talk about like everyday policing, right, and what it means to be in a police state within a community, right? So looking back at when in New York City had stop and frisk, they would stop millions of people, 4 million people. You know, they would frisk 2 million people over like a 10-year period. Some frisk multiple times a day. A lot of them, I think 91% received threats of force from the officer. 90% of people that were stopped were non-white. So you're talking about living in a environment that is full of aggressive policing and what that does to your mental health, right? So we know that contact with the criminal justice system has adverse community effects, but some of those mechanisms that are producing those adverse effects are the policing effect on your sense of duty or obligation to the community, also your political efficacy, your belief that the polis or the governing body will respond to you, or that you are able to bring grievances to your local government or state government. Also, we know that, or researchers found that, contact with the criminal justice system increases feelings of depression, increases nervousness, which is like similar to anxiety. We know it decreases calm, decreases sense of happiness. And so when you live in an environment where that is the case, and that is the case repeatedly, sometimes repeatedly every day, you're living in an environment that has just a constant, your mental health or well-being is just taking a constant barrage of attacks on like a daily basis. And even looking at places like in Missouri, like in Ferguson, Missouri, when the DOJ did their report, they found that 90% of these jaywalking tickets, 90% of the uses of force, all these stops were mostly against, or mostly 90% of those stops were of African Americans. They extracted $1 million to $3 million from the community. And we know it increases in that kind of money extraction from the community, increases instances of poverty. Poverty is also connected with the mental health outcomes. And so to talk about reshaping policing, I think it's better to have a full view of what this policing looks like, and like on a day-to-day, every town type of situation. And then we can start to develop a feel for how we need to rethink and reevaluate how we police situations. The city of San Francisco has started a new process where unarmed individuals will report to incidents that don't require a sworn lethal weapon carrying officer. Going back to the zero tolerance policies in schools, and the fact that our schools don't have counselors and social workers and the like. As a social worker, someone has an MSW, I'm partial to social workers, but it's better to have a social worker in a school setting than a sworn police officer. And so if the future policing means transferring those jobs where you can be, in public, in that type of public office, but be a non-weapon carrying, non-lethal weapon carrying entity in the schools, I think the future of policing looks at how do we direct our funds and services of public policy towards mental health, towards social services, and away from punitivity, away from funding the carceral state, right? Because getting people in jail just exacerbates a whole other problem, actually being in jail, and then for communities missing these individuals. And so I think future policing is going to be a community by community type of process, state by state type of process. But I think we have to first get the total picture of how policing is affecting individuals' lives.
That makes a lot of sense. And perhaps we're in a landscape or an environment where some of these higher profile cases have led us to a place where there's an awareness and a ripeness for people to be willing to have those conversations about funding and where those dollars should go. I Want to take a break for a moment and toss things over to Denisha Snell. Goodness, I'm all tongue-tied there. Denisha, sorry about that. She's been monitoring our viewer questions this evening and may have some for our panelists.
Yes, I do. So our first question is, given that drug addiction is often prompted and worsened by poverty, isolation, and untreated mental health issues, is it fair to say that the drug crackdown of the 60s and on contributed to the return to incarcerating the mentally ill?
Dr. Lee, it seems like you might be a good one to tackle that question.
Yes, I wouldn't say drug use itself has led to greater incarceration, but certainly our attitude toward those who use drugs, and most notable is Dr. Martinson's study in 1972 that looked at a bunch of programs and prison programs and said that nothing works. And that led to our using jails and prisons mainly for incarceration and punishment rather than rehabilitation and encouragement back into the community. And this has led to our diverging from the rest of the Western world, and now most of the advanced economies, in terms of focusing on punishment rather than on containing dangers and restoration. Our imprisonment alone leads to greater violence and danger to society as a rule. And this is what we have seen, unlike other advanced nations that have been able to reduce their violence levels down and also treat people using substances to greater recovery. We have encouraged a very dangerous path of for example, just simply letting those who have addictions out into the street, and there would be overdoses or there could even be deadly withdrawals within prisons. And so these are the kinds of things where we have not focused on prevention and fostering health, but rather the criminal justice system itself has been self-defeating, I would say, for society.
Okay, and Denisha, I believe there's another question that's in the similar vein that we had from one of our viewers joining us this evening.
Yes. What can be done to add crisis counselors or mental health first responders to aid our police departments in de-escalating situations before they turn deadly?
I'm happy to take that one. This is a if you want to talk about politics, this is a heavily politicized topic right now, and I'm sure my colleagues can speak to this. There's one of two schools of thought here. There's one that implies that we should bring some of those social work, mental health functions into our police force so that when the police are out responding to a call, that they have a person right next to them that can de-escalate, that can address some of those issues, side by side with them. There's another school of thought that says, you know what, there's a lot of low-level issues that are raised in communities. A person passed out drunk on the street, or someone who might be talking to themselves, wandering around, and you don't know what to do with that we call 911 or we call the police department for, and we send the police out and it's inappropriate. And what happens if you just send a social worker out instead? And there's a program that's been happening in Oregon for 25 years now, where the first responder is a social worker instead of a police officer. And that's because they've created a system that allows for the system itself to know when to send who to where. So instead of just a blanket response of the police being the de facto response for any type of crisis, they actually can respond much more appropriately. And this is a deeper issue. And I want to say one more thing about this because it's really important. This is, when we talk about stigma is both social and structural. And if you want to see a great example of structural stigma, it's to have a mental health crisis and have the police show up. That does not instill within you safety and hope and comfort. What it does is, for many people, as Dr. Davis said, it instills fear and anxiety, which is only going to make the next time that you have one of those crises, the likelihood that you raise your hand and say, I could use some help, less likely. You're not going to do it. And so I think it's a moment for us as a country, when we're talking about these major, heavy issues, to really examine how we approach the issues of mental health and well-being across a broad continuum in our communities. Just simply embedding a social worker in a police car is not going to solve these problems. We have to think much more comprehensively and much more in depth to really get there.
Yeah, I would agree with that. And I would also say, in reference to the first question about war on drugs and things like that, I would be remiss as a policy scholar not to say that depending on the drug and who's doing the drug, it could be a public health issue. Right? We see with the opioid epidemic is a public health issue as opposed to like meth and crack, which are criminal justice issues. So depending on who's doing it and what type of drug it is, it could be seen as a public health incident. So you don't see the kind of pipeline to the criminal justice system. On the latter point, I totally agree. I think that if you just put police officers in cars, that doesn't change the culture of the institution. And so if you want change of outcome, you have to, reform the institution or bring in a new type of institution to address those issues.
There's certainly been a lot of conversation since the murder of George Floyd about defunding police. I think that term gets a little bit confusing because it's not necessarily about disbanding a police force or not thinking those are important, but talking about the allocation of those funds and what we do them. And Dr. Davis, I hear that seeming to be the theme of what you're talking about, and Dr. Miller as well. We've had a lot of conversation in the Kansas City area over the last couple of years about transparency, crisis intervention training. There was a young man who was 17 in Overland Park in January of 2018 who was in a mental health crisis, was on social media with his friends. They absolutely did the right thing and told authorities when they were concerned that their friend was going to harm himself or take his own life. And unfortunately, the way that whole situation transpired was when police went to the home, there was an officer who had no crisis intervention training. They had co-responders in that department, but none of them were on shift that night. And it resulted in a deadly shooting where the young man backed the family's minivan out of the family garage. And the officer apparently feared for his life and put 13 bullets into that minivan and killed a 17-year-old young man. So, but there are all these conversations about crisis intervention training, which I think a lot of people feel would be an improvement. But part of what I hear all of you saying on the panel seems to be that we need to be rethinking it at even a more granular level when it comes to, Dr. Miller, I believe you're the one who said, who do we send and when and where? Dr. Lee, could you weigh in on that as well?
Yes, I think the discourse that's occurring is very encouraging. This has actually happened in many regions of the world. If we look at policing in Scotland or in Germany, the police do not surveil the neighborhood. They participate. They ask what the inhabitants need. And they often find themselves involved in gardening, in helping people to find jobs. So things that we don't associate with policing. And to completely reinvent the concept of policing is something that many countries have done very successfully. And we know from studies that trying to manage crises with force actually escalates force. In addition to the police brutality, they could end up escalating individuals who have a mental disorder, for example. And we know even in hospitals or in jail settings where programs are in place, that there are many de-escalation techniques that can reduce restraints or isolation. And these methods are it's more dependent on those who are involved in taking care of these populations than more so than behavior coming from the population.
I'm sure we could spend the rest of our evening talking about just those topics alone, but I do want to pivot to a little bit of a different focus. Again, we have watched as COVID-19 has moved from a public health crisis to something that, especially in recent weeks, has been incredibly politicized. Conversations about who's going to tell me to wear a mask, or you absolutely have to wear a mask because it's important to protect those around you. What kind of effects do we expect to see, and are we already seeing from the crisis in the last few months? And what kind of impact does that have on one's mental health? Dr. Davis, I'll throw that question to you.
Yeah, I mean, I think the largest effect is that what I was saying earlier about political anxiety in politics, that people are believing what these political elites, some political elites are saying, that the virus is a hoax, that you can go out, you don't need to wear a mask, and things like this. And I think that is a form of decreased well-being, because you're at the point where you're believing such as like conspiracy theories, right, that are putting your life in danger, your family's life in danger. And I think that's an important political aspect of it, that this anxiety is pushing people to have increased faith in these political elites that are producing the anxiety or anxious producing rhetoric. And it's also making them more susceptible to manipulation, and such that they can be suggested into doing things that are very risky.
I heard you saying earlier, that perhaps people are seeking out affirmation for the things that they already believe or the things that they're already fearful about, and maybe not looking to the best sources for that information.
Mm-hmm. Yes.
Dr. Miller, is there anything that differentiates the lapses in mental health that are induced by this kind of a political climate versus the other kinds of difficulties that are related to mental health?
Yeah, I think that there's a lot actually, and I'll give you a couple examples here, but let me just reiterate one point here. If you look at some weekly data that comes out from Kaiser Family Foundation, when they look at the number of folks that had symptoms or reported being depressed or anxious, it was 36% last week. If you compare that to a year ago, it was only 11%. And so I think that this is this collective issue that we are feeling as a society. And I'll tell you what the difference maker is right now, which I think gives me a lot of concern as both kind of a clinician and a scholar and a policy guy, is the social isolation element. This is the one piece that, combined with the economic downturn, it's like this double-headed dragon of despair. And it's terrifying because if you look at the literature, folks are at higher risk of suicide, drug overdose, and all kinds of other bad behavior, frankly, that stems from feeling like you are at despair, feeling like you are at a moment where you don't have the supports, you don't have the job, you don't have the meaning or the reason to belong. And that's what I think is totally different about this than most of the other times we talk about mental health. Yes, mental health has been a problem for a long time, and we've not done a great job addressing it structurally, as we've already articulated today. But what I think this pandemic has shown is that when we combine some of these major effects of the economic downturn with social isolation, that the reverberations and the psychological impact on our nation is going to continue for some time. And just one example here, we're having a debate right now in this country about when our kids go back to school. And because we've all been in our homes dealing with our kids, hustling and bustling, juggling, I can't say that many parents they're probably ready for their kids to go back to school. That's a totally different issue. But their worry and their concern, are my kids going to be safe? And then the kids and their concern when they go to school, are they going to feel like that they are in a safe place that they can learn? I'm terrified that the emotional distress and some of the change of our nation's psyche is going to continue on unless we address it head on. And that's the last thing I'll say here, is that I feel like the lack of information and that has been put forward around how we should be addressing the mental health side of this has been almost little to none. You don't hear the public health officials talking about this, though we should. This should be the top of every newscast, where we're embracing how hard this is and how it's okay that it's hard and what we can do about managing our own emotional distress. I think that's a huge piece that's not been discussed.
I think that's a great point. And, you know, there are those conversations going on in school districts and private schools and everywhere across the country about what is the right balance. I think parents are having those conversations about being concerned about their children's mental health. And I'm sure that those district leaders and state education leaders are also taking that into consideration. But you're right that it probably hasn't been as vocal a part of the conversation about the physical safety and how do we clean the schools enough, or how do we pay for PPE and those kinds of things. Dr. Lee, I did want to get some input from you about, you know, you have an extensive background studying politics, and how much do you think all of this political climate has an impact on someone's mental health, especially for those who maybe don't pay that much attention to politics in a normal situation?
Yes, I might correct that a little bit in that I had never been involved in politics or considered politics per se as influential as much as policies. And I have advised on policies for a number of governments within the United States as well as internationally. But I think in this current climate and with the conditions that we are under, there is the big elephant in the room that we're not addressing, that in fact we're dealing with two pandemics. One is COVID-19 and the other is a mental health pandemic. And the mental health is being influenced greatly by the fact that we have a leader in government who is unusually mentally impaired. And that distorts our sense of basic need for a parens patriae, that is a government that is capable of taking care of us and protecting us. And that very notion comes into doubt. And what we are seeing is, in fact, the spread of mental symptoms because of the emotional needs of the beyond normal range emotional needs of a president to deny a reality, to fight it, and that's in essence where the politicization of this pandemic is coming from. That there ought to be no politics or partisanship to a health problem. In fact, there's no room for politics in health in general. That's why there's medical neutrality, and you can treat both sides of warring parties, and you can treat casualties as if without regard to their nationality or political allegiance. That's always been the professional training of health professionals, and now we're coming into a situation where politics is disabling us, not just from discussing COVID-19 with straightforward information, but also the mental impairments and troubles in the person in charge of our public health, as well as all the policies that are connected to it. And to me, for me, that takes priority. And not only do we have to have mental health front and center of our national discourse, but we have to find a way to speak also about our leaders, no matter what position they're in, because just like COVID-19, mental symptoms do not discriminate between positions of power or office. They don't stop at the door of the presidency. And not being able to discuss this. And in fact, people may or may not know that mental health experts have been silenced since this presidency in extraordinary ways that has hampered the discourse. And I would actually say has worsened the taboo against speaking about mental health, or has worsened stigma by making mental health issues such a an exceptional issue of obscurity or unspeakable level of embarrassment, perhaps, that we could not have a public discourse about it. As I said before, psychiatry or mental health involves clinical care as well as public health care. And we have been entirely hampered from being able to carry out any public health care regarding this issue. And so I appreciate your giving me a forum to be able to speak about it.
Thank you, Dr. Lee. And I think regardless of someone's political leanings, it would be safe for all of us to say that there has been an inconsistency in the current administration in terms of messaging. You know, Dr. Fauci and Dr. Birx were people who were promoted very early on in the pandemic as being America's experts, and this is who we're going to listen to. And at some point, both of them fell off the map for quite some time, weeks on end, that they were not part of briefings with the president. And it does seem that the administration's trying to find its way and figure out what the messaging looks like. So with that in mind, what more should be done at the federal level by the current administration or the next to begin adequately addressing America's mental health crisis? Dr. Miller?
Well, we can begin by doing what other countries have done when they've gone through pandemics, which is to have mental health experts at the table in any response and recovery plan. That to me is an essential requirement here. There's a lot of conversation, appropriately so, on how to reopen the country and do it safely, how to make sure that we get enough testing out there, which we still don't have enough of, and how to make sure that people have the protective gear that they need to do the jobs that they intend to do in the hospitals and the healthcare sector. But while we do that, we've also got to think about strengthening our mental health system. Right now, there's surveys that have been done that look at some of the places that deliver mental health services are at risk of shutting down, closing doors, turning off lights. And the reasons for that are pretty obvious for most of you that are kind of watching tonight, because we have not been able to bring in the revenue that we used to do before COVID. And so because of that, a lot of folks are having to furlough and to lay off staff and just fire folks, get them out at the door because they don't have enough resources to support them. So what could we do? Well, right now we could put immediately dollars into that system to keep it afloat. Now, I've already said, I think the system itself needs to be restructured and that we must figure out a way to make it more integrated. But while we wait on that plan and while we begin to develop that plan, don't let the system that we currently have just go down in flames. We've got to have something there for when folks ultimately do go back to the clinics. So first of all, putting money into the clinics would be one thing. Second of all, I think having folks at the table that are really creating a plan for mental health during our response and recovery is also essential.
Dr. Davis, what do we know and what do you know from your studies about how our political decision makers are educated on mental health research and practices? How much do they know about the kinds of policies that they need to be promoting and engaging in?
I mean, unless they're on a subcommittee that oversees, funding that goes to like mental health or something like that, I doubt that they're, unless they're a psychologist or something like that, or a social worker, I doubt they have much understanding and much training in mental health or well-being. And I would also add that societies, even our society, is built on norms, right? And some of those norms we codify into like institutions, right? And the institutions help facilitate exchange. So like when you go to the gas station to get gas, you don't think to yourself, I wonder if this is really 87 cents or this is 93 cents. Let me pull out my chemistry set and test this gas, right? You have faith in the institution that that's gas. When you get a burger, you have faith that the public health department has said that this is meat. We came and made sure this is meat. So when you have politicians that break norms, politicians that are constantly breaking norms, it has an effect of destabilizing those institutions because they're built on certain norms. Now, some of those norms may be laws, but a lot of those norms are just a given. You just don't do that, right? There's not a law against it, but for 200 years, no one has ever done that. And so there were like kind of like lines in the sand. And so when you have politicians breaking those norms, right? Consistently breaking norms, it is very detrimental to a democracy. because we need those norms, right? And we need those norms to be upheld without someone threatening to put you in jail for it, because we believe in a free society, right? We believe that people should have the freedom and liberty to go about their daily lives, such that they don't break these norms that we've all decided, or some of us decided to live by and live under. So I think that those politicians that are in leadership that are breaking these norms, it is very detrimental to democracy in states and in the federal government as well, because we're so dependent on those institutions and norms.
That's a lot to take in for sure. Good insight. I want to take the opportunity once again to check in with Denisha and see what kinds of questions the panelists are getting from our viewers online.
Okay, so speaking of policy and kind of politics, Medicaid is currently on the ballot in Missouri and is being considered in Kansas, Medicaid expansion. Is there any evidence that states who have chosen to expand Medicaid under the ACA have had improved mental health outcomes?
So in essence, is there someone who's doing it well? Where should we be looking?
I'll start with that one. First of all, one of the cool things about Medicaid expansion is that we now have 10 years of evidence to show how much it works. And so, as many of you recall, the ACA allowed for states to expand Medicaid to serve individuals that maybe didn't fit within the requirements that were before ACA. So it's been a game changer for many states, and most states have actually done this. So what we've seen from the evidence, number one, probably most important, is it's been able to increase access to mental health services for individuals, pure and simple. And we know that Medicaid, being the largest payer for mental health services in the country, getting more access to care is definitely a foundational principle and something that we should pursue. Number two, for some states, and you'd have to look a little bit carefully at the data, more carefully at the data, it has shown an improvement in outcomes in things like decreasing emergency department utilization. Okay, that's a big one for many states, especially in Medicaid programs. And right now, considering that state budgets are being decimated and Medicaid programs are being cut, mental health funding is right there along with other cuts that are being made, which is a terrifying proposition, especially in the middle of a crisis. But if you really want to get at the heart of politics and policy, there's no better place than spending time on the street corner of Medicaid expansion, because it has become the political football that people use to really go after one side versus the other. And even today, many of you may have saw this, it just happened recently, but the Trump administration has yet again gone to the Supreme Court asking for some states to reinstate work requirements for Medicaid, which is just an insult to injury for those individuals that are on Medicaid, trying to get the best type of care that they can get. And so I would say to the question, yes is the answer, and there's robust data to support the power of Medicaid expansion, both for mental health and overall health outcomes.
Denisha,
I would say that
go ahead. Go ahead, Dr. Davis.
I would even say that before COVID-19, we had evidence that Medicaid expansion was a beneficial thing. There's a great book called Dying of Whiteness, and it talked about Medicaid expansion in Tennessee. And it talked about their decision not to expand actually took years of life off of the population in Tennessee. So not expanding Medicaid in Tennessee actually took years from Tennesseans as opposed to giving them.
Well, we are a country that has been decreasing in life expectancy in the opposite direction of most advanced countries. And that's been going on for the last several years. And one way in which this could be mitigated is by expanding healthcare and making it not only more accessible, but not tied to employment, because that was the one difference that we have made compared to many other countries. And it goes back to how prevention is far more effective and less costly. So trying to cut costs by cutting healthcare actually increases costs in the end, whether in terms of lives or lost time at work, or emergency room care and critical care, as opposed to prevention and keeping people from getting sick in the first place.
That's certainly one of the big topics that opponents of Medicaid expansion will argue about is where on earth do we get the money from all this? And Dr. Lee, what I hear you saying is that investing the money on the other end would be less expensive and more beneficial in the long run. How do we make that transition? That seems like a tricky prospect.
You had quoted this mindfulness program in the British Parliament, and looking at it, it was putting a lot of emphasis on evidence and looking at the science, looking at the evidence and outcomes. If we studied more the evidence, and there's plenty of research available and in copious amounts, in fact, where there should be no question as to what would be more cost-effective as well as effective in terms of improving lives and reducing illness. And so definitely all across the board, expanding healthcare would eventually save tremendous amounts of money. And I think there was a Lancet study that was done also of the United States that predicted that that would be the case.
We certainly talked a little bit, Dr. Lee, you touched on concerns about this particular administration and this particular president, some of the studies that you've done in terms of mental fitness and mental preparedness. But we have an across the board problem with our leaders. What steps can be taken to address the mental health of our leaders, whether it's our city mayors and council members or lawmakers on the state level, all the way up to our administrators and the president? Why is that important to address, and how can we address those questions and concerns?
It is important to address because it becomes an urgent problem when someone with mental impairment is in an important position. That is why we have fitness for duty tests for life and death jobs, such as military officers or police officers, and military officers who handle nuclear weapons go through rigorous testing and have to renew it every year. But for the commander-in-chief, and for many other important positions, we do not have this in place. So that would be the number one anomaly that we could correct. In fact, it's very unusual for such high power important positions not to have a mental health screen attached to as a condition for having the job. Many doctor and lawyer groups now voluntarily have adopted this as a requirement for joining the practice. And we also have more information now that far more important than whatever incapacity a police officer or military officer might display, that policy decisions also have tremendous impact on life and death. It's not only inconvenience, and it's not only preference of one group over others, but it's called structural violence, in fact, when policies cause some groups undue duress or differential access to care and resources, then those kinds of structural changes, in fact, cause far more deaths than overt violence, than all the suicides, homicides, and collective violence combined. In fact, more than 10 times the rates of all those deaths are caused through policy preferential treatment. So more than anything, we need politicians and policymakers to be of rational mind, to be able to consider the science and the evidence, and to be able to put into effect policies that truly better the population as a whole, rather than simply feelings that certain policies would be better over others. We simply have too much science and too much evidence to be approaching policy in such a haphazard way, especially now that we know of the consequences.
Dr. Davis, do you think voters are in tune with that need of their leaders to have sound mental health? You know, it seems pretty basic that we would expect people in the military or people in police departments to have that kind of screening or that training, but it might seem preposterous to some that, you know, you would have that sort of screening for political candidates. I don't know how many of them would submit to that on their own, but do you think that's something that voters are in tune with and understand the need for?
I would say that I don't know if voters are necessarily thinking about the mental health of their representatives. I would also say that people who get elected to, especially federal office, have to subject themselves to security clearances. And so it would be, and those are classified. And so they could simply attach a mental fitness examination to that, and it's also classified. I would also say that, when it comes to picking representatives, the majority of the people usually don't pick their representative, right? We have a lot of states that have the partisan gerrymandering, racial gerrymandering, to an effect where the population does not even reflect the people in the Capitol. A great example of that is Florida. Florida elected the current governor, but also passed overwhelmingly a bill to give felons voting rights, right? Which will allow people to be able to more people to be able to pick their representatives. The Florida legislature then tried to undo the ballot initiative that they put on the ballot, right? So that just shows you that the representatives in Florida don't represent the people of Florida, especially on this issue. So a lot of times I think before we can say that voters are trying to find or are concerned with the mental health or the mental well-being of the representatives, we first have to find out if the voters even have access to the ballot, and is their vote in a representative democracy, right? Are they in a district which is a natural district, which would cause someone to be able to have an equal chance of electing your guy or that person's person? And so we have to look at those things just to make sure people have access and that the board is fair for selection of these individuals.
Certainly Florida is a good example, because if you look at those districts, some of the lines are just very interesting, the way that they're drawn, and divergent opinions. Certainly in that case, you have a more conservative Republican governor, and yet people listening to their representatives in the state legislature hearing different things from those people. So Dr. Miller, is that something that you'd like to chime in on before we kind of pivot to the next phase of the conversation?
Just briefly, because I think my colleagues have said a lot here, and I just want to underscore one thing, that it's okay to have a mental illness or a mental health issue and be in elected office. We don't want to penalize people from having mental health, and I want to just kind of clearly draw a line there. We don't want to try and screen people from running for certain positions just because they had depression or anxiety. The mental fitness issue is a totally different, separate conversation, and I think Dr. Lee had said this really well. So I don't want to, inadvertently leave the viewers to think that we're discouraging people from acknowledging that they have mental health or addiction and can be in these positions, because you certainly can. Recovery is possible. I think the deeper issue here is what happens when you do not have the mental faculties, or you're not necessarily abiding by the recommendations that might lead you to be treated for whatever that might be, and how that could impair your judgment. The mental fitness piece is a much deeper conversation to have. So I just want to make sure that that was underscored, because I don't want people to necessarily think that we're implying something other than that.
I think that's a great distinction for you to make, Dr. Miller. Thank you for adding that to the conversation. So I do want to talk a little bit about mental health care providers themselves. You know, they're certainly trained to work with patients of all different backgrounds and belief systems, and not to allow their own beliefs or biases to interfere with the treatment that those clients or those patients might need. Do you see ways that the current political climate and its polarization has affected the ability of clinicians to stay objective and to be neutral and empathetic with the clients they have who may be of a different political persuasion than themselves? Dr. Davis, I know you have a lot of background in social work, so I thought you might want to speak to that question.
Well, I mean, I would hope that clinicians are taking into account people's political affiliations, but I think it's more so the bigger problem is with a political ideology that dismisses experts, a political ideology that is dismissive of science. That is the greater concern, I think, overall, because those individuals retract from seeing doctors, retract from believing scientific reports or what the news is saying and the like. So I think that is probably a bigger concern, I would believe, than actual clinicians not treating or not seeing patients because of their political ideology. In my state of Alabama, it probably matters more if you support Bama or Auburn if you'll get good treatment than it does if you're a Republican or Democrat. But before that even gets there, to go and seek out the help, I think there are ideologies that block people or dismiss experts and dismiss science that is causing people to lavish in conditions that they don't have to be in.
Dr. Miller, you seemed in agreement there with some that Dr. Davis made.
Oh, absolutely. I first of all, I agree with the Alabama comment. That's
Do we need to take sides on football right now?
But I'm a part of the SEC too here in Tennessee, so we can have that discussion another point in time. But I do think that, this is going to sound a little funny to say, but if your clinician is treating you differently because of their political persuasion, you need to get the heck out of there. That means they're not worth their grain of anything. You just need to go, because the whole point of a clinical and therapeutic relationship is that someone is working with you to help you. And when their stuff gets in the way and you see that, especially if you see it, you got to go. You got to go find somebody else. And I want to empower folks, because therapy and going to clinical care is like a lottery for some people. First of all, it's tough to get into it, and then you never know what you're going to get. If you're not getting something that you feel is value add, that is aligned with what you would expect in terms of a professional relationship that's treating you with respect, then you probably need to find somebody else. And there's a lot of folks out there that are probably more professional and able to keep their political musings at bay. And so I had to reiterate that point because it's an important one.
We've talked quite a little bit about policy in terms of governmental policy, but I think it's also important to have a conversation about workplaces. What do we need our workplaces to be doing to make mental health a priority for their workforce, or to be more supportive of their employees or team members seeking mental health assistance?
I can start.
Go ahead.
Okay. I think it really ought to be a priority on the part of employers as well, because 1 in 5 Americans are thought to be afflicted with some kind of mental illness. And as Dr. Miller said, mental illness per se does not decrease one's capacity to do a job. In fact, there are many people with proper treatment have great ability to fulfill their jobs and sometimes even do better. We have presidents who have had mental illnesses and have functioned as better leaders, or who have been among our better leaders. So mental illness per se does not incapacitate someone, but to be able to offer them the care and make care accessible, to just be able to open a conversation and make it an acceptable topic to speak about, and not to stigmatize the entire individual because of the condition they're struggling with. These are all things that I believe are very well to be done in workplaces, and employers stand to benefit, because when their employees are well, mentally as well as physically, then that increases productivity and our workforce.
So perhaps if we can't appeal to business leaders from the empathetic side of getting their workers help, perhaps there's also some financial incentive in terms of the business running more efficiently, in workers being more productive. Interesting.
Absolutely.
Dr. Davis?
Yeah, I would say differences in exposure to stress plays a significant role in explaining variations in well-being. So two people can work in the same office or department or whatever, and they can experience that department or office completely different. And so I think we have to be mindful of not piling stress onto employees and making the environment open and welcoming to all employees. And so you don't have people, you don't have like people of different races, ethnicities, genders, people, you know, different statuses, making sure that they are welcome and open in those environments, such that you're not piling on stress, right? So we never know what a person may be going through, but it's always, you know, if you can avoid it, and you should avoid it, especially in the workplace, to piling on stressors to individuals simply because of their place within society, I should say.
I just have to add to that. That's so important, that one of the things that employers can do almost overnight is to create an environment that really fosters well-being. That looking at things that might cause undue stress from work environments and toxic leadership, all the way down to simple things like, do you have healthy foods available for people to get access to? There's a lot of things that folks could do in the employer space to really foster that psychologically healthy workplace environment. There's also other things that are a little bit more deep. For example, when most people probably watching this tonight have health insurance coverage through their employer. Employers can play a major role in making sure that what they're purchasing for their employees is comprehensive enough for the mental health and addiction side. Now, we've had a law on the lands for over 10 years now that requires insurers to pay at parity mental health benefits as they do medical benefits. It's not always enforced well, and people still get denied care and pay out of pocket more than they should. But employers could really do a really wonderful job by demanding more for what they're purchasing for their employees. And the last thing I'll say here is that I think that we need to offer both on and off-site supports for individuals around mental health. We used to have employee assistance programs that were everywhere, and that if you had a mental health or addiction issue, you could have a triage type of service from an EAP. And that might be well and good for some folks. But now we need to make sure that we're delivering some type of off-site provision of care too, whether it's through telehealth, it's some type of peer-to-peer network that you use through your device, whatever it might be. Employers really need to understand that just because their employees check out and go home doesn't mean that the responsibility that they have that their employee just goes away. You got to take care of people from morning to night. And one of the ways that we could do that is to make sure that they've got good services that follow them.
I want to do one more quick check-in with Denisha Shell, our roving reporter who's been keeping an eye on the comments coming in for the panelists this evening.
Okay, let's do one more about pandemic response. So it said you've spoken about many societal factors that affect pandemic response. For example, politicians modeling bad behavior. Can you think of any behavioral health approaches that could help nudge COVID skeptics towards safer, educated behavior instead?
Wow, that's a big one. Any of you want to tackle that one first?
Yeah, I would say that the leadership matters. And so any public administration school is going to tell you leadership matters. And if the leadership in the area took it seriously, then other individuals would take it seriously. I think that's important to say. And also, I think, back to what Dr. Miller and Dr. Lee were saying earlier about empathy. I think in political science, we call it political solidarity. It's the ability to see the pain and suffering of your fellow citizens, and you acknowledge it. And you also acknowledge their ability to pull grievances, to come to the government with grievances because of their pain and suffering. I think that it also matters who is getting sick, right? It also matters who is dying to facilitate where that empathy is going and how fast it's transmitting between different groups of people. So, but specifically, I would say leadership does matter, and you can see the states with the different types of leadership within the different states, there's information to show that in this current climate that the states with women governors are doing a lot better than states with male governors. You see that certain people that jumped out early are better, or jumped out early and independent of the federal government are doing better. But also states where I think that political solidarity is stronger than in other areas.
Thank you, Mr. Davis. I'm looking at the clock and realizing we're nearing the end of our time, which seems hard to believe. We've covered a lot of territory. Those of you who have joined American Public Square in the past may know that it's the tradition that we allow each panelist a final comment. We do this in the form of 2 brief questions. The first is, so what? And the second one is, now what? So I'm going to start, Dr. Lee, with you to answer those questions as I pose, so what and now what?
Well, in terms of the so what, I would like to actually go back to Dr. Davis's comment about how leadership that shuns expertise or denigrates expertise makes a big difference, we've seen. That can be seen in an overall picture, that the mental health of a leader matters a great deal. And when we do not fully have that, and there's a reason why thousands of mental health professionals came forth about this current presidency in ways that were unprecedented in US history for any president of any party. When we have a situation like that, we do have to address it. We see the difference, not just in terms of espousing or rejecting expertise, but at every level in others' ability to carry out scientific guidelines, for the public's receptiveness of not seeing it as tied to the president's pressures or not, and therefore allowing expertise to address the problem at hand, just like the pandemic, would do much better with medical experts' input. Our handling the president's situation would do much better with mental health expert input. And so now what do? I spoke about standardized tests, but these things do not come about by accident. In fact, we have an impaired leader because of certain conditions in society. I have said in the past that it reflects a state of poor public mental health when so many people are attracted to an impaired leader. So we can fix many of those conditions. We know what they are, and we have the science available to be able to address these issues. So to be able to talk about mental health in our general discourse, I think would go a long way and go a long way to addressing those issues in society.
Dr. Lee, we certainly appreciate your perspective and your input for tonight's conversation. Thank you. Dr. Davis, I'll turn next to you with our key questions of so what and now what.
Well, I think the so what is that if you're concerned with mental health, if you're concerned with criminal justice policies, if those 2 things are trending. So they're politically salient, and that means that now you can actually get some traction in these state houses, in these mayoral offices, in the counties, and possibly at the federal level. You can get some policy passed or some policy reforms that can address some of these issues. So I think the so what is that it's salient, and you have to strike while the iron is hot. And so now you have to push for your local politicians, state politicians, to pass laws that will address some of these issues.
Get out there and do something about it.
Mm-hmm. Vote.
All right. Thank you so much, Dr. Davis. And Dr. Miller, we'll finish with you this evening with the questions of so what and now what.
Well, thanks, Janet. Thanks for your wonderful moderation this evening, and thanks for American Public Square for highlighting such an important issue. So what? Mental health is foundational to our health, period. Any attempts to ignore that means that we're going to pay more, we're going to get less. It's not going to be as satisfactory, and it will be to the downfall and detriment of our society. Now what? Turn to each other. Turn off your computer when you're done with this tonight. Go to your friends, go to your families, go to your next door neighbor, socially distancing, of course, and have a tough conversation. Ask how they're doing and be okay when they say, I'm not okay. Embrace the awkward and understand that we are all in this together. If we're going to listen and learn and love and support one another, now is the time. So what can we do? We move to action. And the best action that we could take right now is just to be there for one another. So thank you.
Wonderful words to resonate for the close of our evening. I want to thank each one of our panelists very much for taking the time and enlightening us to some of these different circumstances so that we can be the kind of change that we need to see in our communities. I know our viewers all join me in thanking you for your time and your perspective and insight on these topics. So for now, I'm going to turn things back over to Denisha to wrap up our evening.
Thank you, Jana. So I want to end the evening by saying thank you again to our panelists, Jana, our moderator, and our fact checker. This has been an excellent and very enlightening conversation. To those in the audience, thank you for taking time out of your evening to join us in this important discussion. You can learn more about these series as well as access the fact sheet and mental health resources at our website, americanpublicsquare.org. Tomorrow morning, we'll be sending out a short post-event survey, and I ask that you please take a few minutes to fill it out. Your feedback helps us plan our events, and it's greatly appreciated. Once again, thank you to everyone, and have a great evening. Bye-bye.
Thank you.
Thank you.